Hello everyone, it is Kierra and Sophie, and we are here with another episode of KSSK CMD Chat. I'm going to talk about pulmonary function testing. Some people have never done this before. Kierra and I have. What did you think of them when you did the PFTs?
The first time I ever took a pulmonary function testing, it wasn't even the stereotypical testing you do. It was one of those like plastic things that had a little disc.
Yeah.
And whenever you breathe in, the disc goes up.
I'm getting a message from our team.
Inspirometer, thank you. We're getting a message from our team. That was the first thing I ever used, and that was when realized that something was a little bit off with my breathing.
I remember the thing where it told you like your score, and I would like kind of treat it like a game. I'm like, I'm gonna get a high score, you know? So those are the ones where you have to like blow as hard as you can, like out, or like inhale as hard as you can. And I don't think you notice until like you do those tests how much harder it is to breathe like without your nose. There were other ones too, the ones where like you had this thing in your mouth, but it was like really big. Like it wasn't just like a, I have tea right here. It wasn't just like a straw like this. It was like
a tube.
It was like bottle caps that are bigger, and you put it like in your mouth, and it's like hard, so way harder to breathe out of it because it's like wider, you know?
What was like the most difficult thing for you?
Maybe the birthday candle one. Or I don't know if it's birthday candle for everyone, but there's always a simulation like on a computer, and you have to like blow. The person's like, okay, blow as hard as you can. And then you're supposed to blow out birthday candles. Sometimes you're just blowing a man off the screen. Like, you know, the man just goes like whoosh, you know, he just eats. So those are pretty hard because I don't know if it's actually harder, but it's just more frustrating because you're like, yeah, I'm going to blow out all these birthday candles and you can't even get one.
Oh.
I'm not like emotionally scarred from that.
I'm excited to learn about PFTs today, actually.
Hopefully a lot of people will learn why they're super important.
And on to our interview. Hello everyone, welcome back. I am very excited to be joined once again by Dr. Meyer, and we have a new person joining us, Dr. Boo, and we are going to learn more about PFTs, also known as pulmonary function testing. Wait, Sophie, don't you know Dr. Boo?
Yeah, she's my pulmonologist. Hi, Dr. Boo.
Hi.
Because of all COVID, I haven't been able to give you a visit, but it's great to see you. Yeah.
That's great that you're keeping healthy.
Yep.
Now we know your names. Would both of you mind introducing yourself for everyone else at home?
I'm Mimi Boo. I'm a pediatric pulmonologist at Stanford University, Lucile Packard Children's Hospital in Palo Alto, California.
I'm Hank Meyer. I'm a pediatric pulmonologist at the Children's Hospital of Philadelphia. In addition to seeing neuromuscular patients, I'm the medical director of our pulmonary function testing lab.
So what is the purpose of pulmonary function testing, and why is that important for someone with CMD like me and Kierra?
Your breathing muscles are really important to help you breathe. It brings oxygen to your vital organs like your heart, your brain, your muscles, and so it helps you do all the functions you need to do during the day. And so what pulmonary function testing are is some tools and some ways to measure how strong your muscles are and how well your lungs are functioning. So CMD is a general term, right? So you guys all know that different people have different types of CMD, and the muscle strength is different for each of the different types in terms of how the muscle strength changes over a person's life. And so the lung function testing helps track that change over time.
I do remember actually having to do multiple different types of tests. Would you guys mind helping list those out for us?
So we do, for regular testing, we do two main measurements. We do a test called spirometry and then muscle function testing called MIP and MEP. So with spirometry, what we have you do is take a big deep breath, fill your lungs up as deeply as possible, and then blow out as long and as hard as you possibly can until all of the air that you can blow out of your lungs has left. And that tells us a couple of things that are very important. First, it tells us the size of your lungs, how much air you can breathe in and then breathe out. And it also can tell us how strongly you can breathe out. So the advantage of doing a breathing in and breathing out test is that you need to use both your breathing in muscles, your inspiratory muscles, which involve your diaphragm, and then your expiratory muscles, which primarily include your abdominal muscles. So Dr. Boo was mentioning that certain types of neuromuscular disease or CMD will affect different types of muscles, and you can sometimes see that in some of this testing. The other thing is that you can measure the force of exhalation by how fast the air comes out right at the beginning using something called peak expiratory flow. We then do testing where we have you take a big deep breath, and then right when you start to breathe out, we close a shutter so that no air comes out. And instead we measure how strongly you're able to blow air out. And that's called a maximum expiratory pressure measurement. And that again will measure your abdominal muscles. And then what we can do is say, okay, breathe all the way out until your lungs are completely empty. Then try and breathe in as hard as you can. And then we also will close the shutter, preventing you from breathing in. And we measure how much pressure you can generate to breathe in. And those measurements are very useful to look at both expiratory and then inspiratory muscle function. The problem with those tests, the MIP and the MEP test, is that they're really hard to do for anybody. And what you have to do is when you're breathing in or breathing out, you have to hold that pressure for at least a second. Doesn't sound too long, but it is difficult. And because of that, because of how difficult it is, it can be a little bit variable, meaning you can get numbers or values that are all over the place. And sometimes that makes it hard to be able to interpret reliably.
I remember doing these tests, and sometimes I'd get like really frustrated with them. I'd be like, I need to blow out stronger, and then I like couldn't. You know, like the birthday candle ones, like those are so frustrating because I sometimes I like barely get one out, and I'm like, okay.
And then I bet you probably have a therapist training you or helping you do the testing who's hollering at you to breathe out and blast the air out and really coaxing you to breathe out as hard as you can, where I'm sure you're already doing that and you just want to look at them and tell them to be quiet.
Scariest test I remember I had to do was one where instead of it blocking as I was trying to breathe out, it would block when I was trying to breathe in.
Yeah, that's the MIP test.
That one wasn't fun.
You bring up a good point, which is that for some patients, a lot of patients, they find the lung function test really stressful, right? Because it's trying so hard to do the best you can, and sometimes the values are not what you expect. But I think that it's important that you try, and as the lung doctors, we realize this, right? We realize that these tests are hard, and we take it into account of the whole patient, right? It's one of the values that we look at. And we also look at, what time of day it was done, things like that can affect how the results of the test as well. Because
it's difficult to do these tests, somebody came up with an alternate approach to the MIP, the maximum inspiratory pressure test, called a SNF. And the SN stands for sniff. So everybody's used to, sniffing. And that's a more natural movement. And so what they'll do is they'll take a catheter that has a little pad around it, and they put it in your nostril, just right at the edge. And then it seals, and then they say, okay, Kierra, take a big sniff in, and you do that. And, it's easier to do reliable, get reliable data that way. And it's easier for even younger patients to do that. Certainly doing the MIP maneuver.
That's
interesting. That makes sense now.
So why is it important to measure cough strength, and what would having a weak cough mean to someone like me? So coughing is part of your normal immune system and normal mechanism to clear mucus from your lungs. So I don't know if you knew, but your lungs are always producing mucus. Mucus is part of the normal immune system of the lung because your lung is connected to the world. When you get a virus or get a cold, your body, as part of its immunity, creates extra mucus. And part of normal recovering from a cold or a virus is to cough mucus out, move that mucus out of your body. And so people who have weak chest muscles and weak cough have trouble getting this mucus out. And so then you can get something called a pneumonia, which is when the mucus gets stuck in the lung and then your oxygen level isn't really good.
and then it also can produce something called pneumonia as well. So when we see that someone has a weak cough, either based on the history we get or by measuring the number, then we can use extra different tools to help with the cough and help make the cough stronger.
That's the reason I have a cough assist, right?
That's right. Cough Assist is a brand name for a assisted cough device.
Mm-hmm.
It's a machine that pushes air in and then yanks it out to help stimulate a cough and help move mucus that's far out in your lung into the middle of your chest, so that way then you can have a smaller cough and cough it up and then swallow the mucus or spit it out.
What role does fatigue play in getting an accurate PFT result?
Excellent question. Thank you for asking that. And the simple answer is it plays a huge component in determining what type of lung function you can produce. It's just like if you do anything where you have to work as hard as you possibly can, if you don't feel up to it, then you're not going to be able to perform as well as you would like. And just for some perspective, when Dr. Boo and I each see our patients, we really appreciate and use lung function. But we obviously spend a good bit of the visit talking to you, asking you questions, and then examining you. And so it's just part of a larger assessment. And so if you don't feel great, maybe you have a stomach ache, or maybe you fell and your ribs might be sore and you just can't do testing the way you usually do, well then we'll say, you know what, no big deal. We'll go with our history and our physical and try again next time.
If something doesn't make sense, we can always check it again, right? Or we do it earlier in the morning, or we do one of the tests before another test.
So I know there might be some younger viewers watching that maybe don't know when they should start pulmonary function testing, and maybe they don't know how often it should be performed. Do you mind explaining that?
Lung function testing requires following instructions, right? So we usually think that when kids are going to school, and then that's when they really can follow the instructions necessary to do these complicated maneuvers sometimes. Yeah. And so I think usually around 6 years old is a reliable time to start, although sometimes we can start earlier, around 5 years, if we feel like the person can follow the instructions pretty well. And then in my practice, usually I check lung function again every 6 months. I do it more often if there's something off or something we're worried about, then we do it sooner. Especially like you mentioned, like say a person was feeling tired, the numbers are off for the day, then we likely would repeat it again in 2 to 3 months to just confirm the results.
What PFT results would indicate that we need either something done or maybe more testing?
So one of the things that we do after we get the testing is we compare the data to the previous testing. So let's just say, to throw out a number, that your vital capacity is 70% predicted and the lower edge of normal is 80. And so we say, well, your lung capacity is low. Then the question is, well, where was it the last time? If it was at 70 the last time 6 months ago, then you say, okay, it's stable. If it was at 90 6 months ago, then that's where we would say, wow, something has changed and that's not good. We know that on average, we'd expect to see a loss of maybe 5 percentage points per year. So if you had lost any more than that, then we would start saying, well, what else has happened? And we would wonder, have you become weaker? Is your scoliosis progressing? Do we need to involve an orthopedic surgeon? If you've gotten sick, and let's say that this is a follow-up from hospitalization, and your lung function has declined more than normal, sometimes we can say, well, this may still be that you're weak from when you got the flu. We may not do anything different. Or you may say, you know what, I just have this cough that hasn't gone away. Then maybe we would look at the possibility of treating you with something for your cough, perhaps an inhaler or a nebulizer treatment. The simple answer is that we try and put things in perspective based on historical data where you've been. And then that is really, really important in then allowing us to get a sense of whether we need to look at new treatments or new types of therapies.
So what other tests are there to evaluate whether someone with CMD is experiencing trouble with breathing, and when would these tests normally be performed?
Some of the other tests are done is something called a pulse oximeter measurement. So if you ever remember the red light on your finger,
Oh yeah.
that measures the percentage of your something called hemoglobin having oxygen bound to it. So that can be a sign of inadequate breathing if it's low. We also can measure CO2, which is carbon dioxide. So your body brings in oxygen, but it also breathes out CO2, which is your waste gas. And there are different ways to measure that. Some offices have a way to measure that through your skin. You can measure it with a cannula over your nose. You can also measure it in your blood. So blood work can also be done too. With those testing, the oxygen level is recommended to be checked at every visit with your lung doctor. And then for the blood work, it's kind of variable, but recommended to be checked once a year in some way.
I always feel like E.T. with the thing on my finger, the red light.
I'm impressed that you know your movies so well, Sophie.
Of course.
E.T. is a little bit before your time.
Well, I'm not a normie. I'm quirky.
Small tip for people who get the red light done on their finger: make sure your finger is warm. One time they tried to do the test and it just wouldn't work because my hands were too cold. I couldn't read it. So we needed to wait 5 minutes as I was just aggressively.
First.
Thank you guys so much for coming.
Thank you so much.
Yeah, this
You're
has been
welcome.
awesome.
Thanks for such
It's
good
great to see you.
questions.
Take care out there.
For more ways to stay connected, download the CMD mobile app and sign up for the newsletter. Here is a link to the CMD Pulmonary Guide, which is very interesting. And if you have questions, email us at breathe@curecmd.org. And wait, before you go, be sure to like and subscribe. Add your comments below to keep the conversation going. Thanks again for watching. Bye!